Well, hello, everyone. Thank you for joining this webinar about the lifetime management for patients with aortic stenosis and small aortic annuli that is sponsored by Abbott. We have a good expert panel of some esteemed faculty here, and we have Ibs Sultan, Dr. Sultan, who is the head of cardiac surgery at UPMC and one of the PI and the national PIs for the Envision trial for the Navitor for the low and moderate risk patient. We are also pleased to have Sachin Goel, who works in Houston Methodist, and he's the medical director of the structural heart intervention there. And I'm Basim Shihab. I work at Ascension Via Christi, and I'm also one of the PI, the national PI for the Envision with the rest of the team. It's really pretty straightforward agenda for today. We're going to talk a little bit about some data about the heart team and some of the small annuli consideration. We're going to talk about a pre-recorded case with the Navitor and looking at valve selection and certain clinical decision-making on why there's some benefit of that system in these certain anatomies. And then we're going to open that up with the panelists for case discussion and some post-procedural management, and to finish up with the QA and key takeaways for the webinar. From a conflict of interest for the faculty, this is my conflict of interest. This is Dr. Sultan, and these are Dr. Goel. So please, let's keep this as an interactive kind of webinar, and let's do our best to if you have any questions, please send them in the chat, and we'll be more than happy to answer them. And we're going to be interacting together as the panelists and the faculty discussing these presentations. First section is about the heart team, small annuli consideration, and the kind of critical thinking on what we need to do and what are the potential solution for these kind of anatomies. Certain valve design considerations we have to look at. First thing we look at as a heart team is, well, is it a balloon expandable or self-expanding valve? Are we in need of an intra-annular or supra-annular designs? We look at the frame height, we look at the leaflet position, and we look at the leaflet height, technically the risk plane for the second valve, and the hemodynamics needed for that certain patient. These are two key features that we look at. We also always look at how would the second valve sit, and what are the needed hemodynamics for this patient. A patient with a BSA that is much higher than average, the hemodynamics will be quite different when you have small annuli. We also look at potential commissural alignment needs and, of course, coronary access. So really, when we're looking at valve design consideration, we're looking mainly at what is the best thing for the lifetime management of this patient, and what is the best thing for this patient, not just for this first case, but for the next decade or 2 decades or 3 decades of their life. So why Navitor and when Navitor? Really good question, but really high-risk patient based on the STS or incremental risk. And mainly in our program, our Navitor use is definitely for small annular sizes in cases where we need coronary access or re-access and re-intervention because of the wide and the large cell design. Patient with 80 to 85 millimeter annular perimeter and adequate sinus width. The Navitor does very well in very horizontal anatomy, even though it's self-expanding, but the fact that it has the flex nav system, it's self-centered itself and deploys very well in horizontal anatomy and also in tortuous routes from the iliacs all the way up. And that's our preferred method to get these patients treated with that system. Of course, we talk about the desire for annular valve and lifetime management. And also, whenever we have borderline sizing of another platform, and that fits well with the Navitor platform that we have. Some data and some insights why that's important in these anatomies from the Japan Ocean TAVI registry. As you know, that registry is an ongoing prospective Japanese multi-center registry. Over almost 15,000 TAVI patients as of 2021. As you know, the Asian population have an average very much smaller aortic annuli than the Western population, and they usually receive smaller prosthetic valve than the counterparts. Patient with small annuli had remarkably high residual pressure gradient after the implantation of a balloon expandable valve. So we see much higher gradient on echo when we use a balloon expandable valve. What we have found is that low incidence of severe PPM at 30 days or patient-prosthesis mismatch, even in valves that are less than 23 millimeter or equal to, 84% had really insignificant PPM at 30 days in these small annuli. That Abbott TAVI delivers consistent single-digit gradient, minimal PPM, even in small annuli and even in small valve usage. As you see here in the Ocean TAVI registry, as you see in the German and in the SMART trial, much more consistent and much more predictable single-digit gradient, despite being self-expanding and an annular system. The Navitor valve and the Evolute FX, both of them demonstrated single-digit gradient in small annuli patient. However, the difference is one is annular and one is supraannular, so definitely a benefit for lifetime management and definitely for coronary access, at least an immediate face value. And as you see in here, the gradient is single-digit despite looking at small annuli and looking at smaller size valve. There's definite proven performance in small size valves where they have unmatchable mean gradient single digit with an EOA that gives you, that is the largest that we've seen in the 23 millimeter and also the 25 millimeter Navitor valve. And I'm going to now give it to Dr. Goel to continue the rest of that part.
Thank you very much, Dr. Shahab. And thank you, Abbott, for the opportunity. So the coronary access, as you know, all operators are now familiar and aware, is a very important part of TAVR and ongoing care of TAVR patients. One of the main challenges with a tall frame valve, self-expandable valve, has been the fear of being able to access coronaries for percutaneous coronary interventions after TAVR, especially in the setting of an acute MI, in an emergent setting, particularly for operators who are not very familiar with the TAVR valve platforms. Even though every hospital has TAVR operators, interventional cardiologists and surgeons obviously doing TAVR, but there are many more interventional cardiologists doing percutaneous coronary interventions, who take call and do PCIs. So this has sort of been one of the issues with a tall frame valve, and one of the reasons why, the tall frame valve has not been very popular up until now. The big advantage with the Navitor and the difference between this tall frame self-expanding valve and the other tall frame valve is the geometry of this valve is very different. As Dr. Shahab mentioned, the leaflets are annular as opposed to supraannular. So these leaflets are going to be much lower compared to the other self-expanding valve, the Evolute valve. In addition, the other important difference is the cell size. The cells are much larger, as you can see in the picture there. Depending on the valve size, the cell size actually increases. So 14 French, 16 French cell, you can get any coronary catheter through there without any difficulty and without worrying about interacting with the leaflets, since the leaflets are intraannular and not supraannular, like they are in the Evolute valve. So coronary access for elective PCIs or in the setting of acute MI, STEMIs, non-STEMIs, is not an issue with the Navitor valve. And we have seen this, and we've actually, in our early experience, we used to engage coronaries after doing TAVR, and within a matter of seconds, we can engage both left and right coronary arteries without any issues. So this is a huge plus, huge advantage, in contrast to the other valve. I want to focus on the, a little bit on the future, the redo TAVR. we are all starting to see patients who have had TAVRs in the past. Some of them have started to come back with a degenerated valve. Granted, some of these patients are older, sicker, some of them have dialysis, some of them have other comorbidities, but nevertheless, all TAVR centers are starting to see patients with degenerated TAVR valves who have come back for a repeat TAVR or a redo TAVR, or what we call now a TAV and TAV. And one of the main concerns with a TAV and TAV is the risk of occluding the coronary artery by putting a second TAVR valve. When you put a second TAVR valve inside a index TAVR valve, you create what we call a neoskirt. The pinned up leaflets of the index TAVR valve are going to stand up, and that's what a neoskirt is. And depending on the location of the leaflets, depending on the coronary heights, depending on the anatomy, the sinus width, and the STJ width, you could run the risk of sinus sequestration and coronary occlusion, as you can see in these pictures. So the big difference in this self-expandable tall frame valve, the Navitor valve, versus the competitive valve, we can keep it simple. The only competing valve that is approved in the United States is the Evolut valve, is again the location of these leaflets. So as you can see very nicely on these pictures, the annular leaflets are lower as opposed to the Evolut valve where the leaflets are higher. So the neoskirt, as you can see here, is going to be much taller with a Evolut valve as opposed to the Navitor valve where the neoskirt is going to be lower. We're talking mainly about putting a short frame valve, which is a SAPIEN valve, inside either of these valves, right? That's the only valve that is currently FDA approved, is a short frame valve and a tall frame valve. We've also done the other way around, but that's not FDA approved yet. So we're going to focus for the purposes of this discussion, putting in a short frame valve in a tall frame valve, meaning putting in a SAPIEN valve inside either a Navitor valve or the competitive valve or the Evolut valve. So if you imagine putting in a short frame valve, the SAPIEN valve, inside the Evolut valve, because the leaflets are supraannular, the neoskirt is going to be taller. So the risk of coronary obstruction or coronary occlusion with the neoskirt is going to be higher. In addition, the risk of sinus sequestration is higher because, again, the leaflets are higher. In contrast with the Navitor valve, these valve leaflets are much lower, they're annular. So the neoskirt height is going to be much shorter compared to if you put a SAPIEN valve inside the Evolut valve. So this is a huge advantage in terms of a feasibility for a redo TAVR in the future. I hope that is clear. If there are any questions, we can certainly address this as we go along or later on, whatever is feasible. In my mind and in the minds of people who are using this valve, the Navitor valve offers the best of both worlds. When we look at TAVR, what do we want? What do the operators want? What do the patients want? Well, we want excellent hemodynamics, which we know that the self-expandable supraannular platform provides. There's a lot of data from the Evolut platform. We also want the uncompromised coronary access, which we all know that when you have a SAPIEN valve, the coronary access is really not an issue. So we want the hemodynamics of a self-expanding valve, and we want ease of uncompromised coronary access for future PCIs. And the Navitor really provides the benefits of both platforms in one TAVI system. So you have low gradients across all sizes, which the Navitor provides, uncompromised coronary access, which, as we discussed, the Navitor valve provides, and then the low leaflet height for future interventions is something that the Navitor provides as well. So in simple words, it is a best of both world valve platform, which makes it very attractive for patients. Right now, as you know, it is only approved for high surgical risk patients. But as Dr. Shahab mentioned, the ongoing ENVISION trial is randomizing patients who are at low surgical risk and intermediate surgical risk to the Navitor valve versus one of the commercial TAVR valves, the Evolut or the SAPIEN platform. So that's a very, very important trial. And, audience members who are obviously participating in this should try and enroll as many patients as possible. This is an important study that just came out in JACC Interventions. It's in the format of a letter, but it's a very nice study. This study looked at, this is from Copenhagen, Denmark, from Ole de Becker's group. So they studied the impact of the TAVR valve design and implant strategy on redo feasibility, redo TAVR or TAV and TAV feasibility. So what they did is they looked at over 100 patients, I think 106 patients who underwent TAVR using the Navitor platform, and they did a CT scan on all those patients. And then based on the Navitor implant depth, is my cursor showing up on the screen? I don't know if my cursor is showing up on the screen, but based on the depth of the Navitor, they categorized these CT scans or these patients' CT scans as high implant, which is less than 3, standard 3 to 5, low more than 5 depth. This is the depth of the Navitor implant in relation to the annulus. And then they simulated a SAPIEN in Navitor, meaning a short frame valve inside the Navitor. Depending on the position of the implant of the SAPIEN, this is a simulation. So patients all had TAVR with the Navitor valve, and they simulated the SAPIEN inside the Navitor, okay? So this is not they're not putting in a SAPIEN inside the Navitor, but it's a simulation. This is how the feasibility of redo TAVR is assessed. That's how it was studied with the other valves, for example, for a SAPIEN in SAPIEN, and also for a SAPIEN in Evolute. So the same methodology was used, and depending on the position of the SAPIEN, they called it high or low SAPIEN. For a low SAPIEN, the outflow of the SAPIEN was at the second node of the Navitor, and for a high SAPIEN implant, the outflow of the SAPIEN was at the commissure tab. Based on these positions, they looked at the risk of coronary occlusion or coronary obstruction. And this is typically determined by looking at 3 things. You look at the coronary risk plane, which is the lowest of the 2 coronaries from the annulus. You determine the neoskirt plane, and then you determine the valve to aorta distances. So for example, if the neoskirt plane is below the coronary risk plane, the coronary obstruction risk is considered to be low. On the other hand, if the neoskirt plane is above the coronary risk plane, then there could be risk of coronary obstruction. In that case, they measured the valve to aorta distance for both the right and left coronary arteries, and that is categorized as low, intermediate, or high if your valve to coronary distance is more than 4, 2 to 4, or less than 2 respectively. So when you look at the middle panel of this figure, you can see with a high SAPIEN implant, the risk, by the way, based on this simulation, is highly variable depending on where you put the SAPIEN implant. We've learned from other platforms also that the higher you put the SAPIEN, the higher the coronary risk. The lower you put the SAPIEN, the lower the risk. But in the Navitor platform, this is obviously variable based on the high implant. But when you have a low SAPIEN implant, which is favorable with this platform since it's an intra-annular valve, there's no difference. The risk of coronary obstruction is 0%, 0%, and 2%. It doesn't really matter when you have a outflow of the SAPIEN at the second node. Of course, with the higher SAPIEN, the risk is higher if you have the SAPIEN implanted higher in the Navitor, 73%, 43%, and 28%. But important point is with a lower SAPIEN implant, there is no difference in the coronary risk occlusion risk based on these simulations. In addition, importantly, in the same study, they also compared this coronary obstruction risk across various self-expandable platforms. So on the left panel, you see the SAPIEN in Navitor. In the middle, you see SAPIEN in Accurate. And on the right side, you see SAPIEN in Evolute. So when you see the simulation based on the high implant for the S3 in the TAVR, the risk of coronary obstruction was much higher with the index Evolute valve and Accurate valve, 75% and 60% versus 39% in the Navitor. And then when you have a low SAPIEN implant, you have much lower, almost all patients are not at risk for coronary occlusion with the Navitor valve, 1% versus 8% and 20%. So the Navitor valve is favorable for a redo TAVR in contrast with the other 2 tall frame platforms. We now know that the Accurate obviously is not going to be a commercially viable option, but predominantly in comparison with Evolute, you can see the difference that the redo TAVR, based on this feasibility study in over 100 patients, this is a very feasible and more attractive option for a redo TAVR standpoint. Last couple of slides, strategies for small annuli patients. So Dr. Shah briefly alluded to this. there are different permutations and combinations, right? We talk about this as a lifetime management strategy. When we see a patient, say in his mid 60s or late 60s or early 70s, who has a life expectancy of 10, 15 years or more, we have to discuss always the lifetime management. We always have this discussion in the valve clinic, that they may need more than one valve in their lifetime, since, any one bioprosthetic valve is unlikely to give them 20 years, be it a TAVR valve, be it a surgical valve. So there are different permutations and combinations. For example, you could do a surgical intervention or a SAVR first, followed by a TAVR, followed by a redo TAVR. What are the pros and cons of this? So the pros are, obviously, we have a lot of data and we know a lot about doing TAVR and SAVR. Feasibility of coronary access is much better for a TAVR and SAVR because the native leaflets are gone after a SAVR. And then, of course, surgery at a younger age is lower risk than surgery at higher age. What are the cons? Of course, there are fewer options for fourth procedure. I mean, I don't know that, a lot of patients will need a fourth procedure, especially if they are having this, we're talking about late 60s or early 70s. Of course, younger patients will have, more interventions during their lifetime. But the con will be the difficult coronary access after a TAV and TAV and high risk for coronary obstruction. The other combination, of course, is doing a TAVR first, followed by a SAVR and then a TAVR. The benefit, of course, is, there may be a feasibility of fourth procedure, which is a redo TAVR. TAVR and SAVR is a feasible third procedure, minimally invasive procedure at young age. Of course, there is limited experience with TAVR explantation, and we'll talk briefly in the next slide, the risks of TAVR implantation and the risks of other concomitant procedures. TAVR, theoretically that may be an option, but obviously that has more cons than benefits, and there's no real data on this. Finally, the explant TAVR. So this was a large multi-center study that Gilbert Tang and Syed Zaid, who was our former fellow, who's now faculty at the Baylor VA system here, they put together this almost 30 centers, almost 400 patients. They looked at the outcomes of TAVR explant versus redo TAVR after a transcatheter heart valve failure. And you can clearly see the mortality at 30 days was significantly higher in the patients who had TAVR explant, 13.6% compared to 3.4% in those undergoing redo TAVR. And why is this? This is not necessarily a reflection of the procedure itself, but multiple factors have contributed to this. These patients are elderly, they are sicker, they have a lot of comorbidities. When patients have TAVR explant, it's not just a TAVR explant. Sometimes they have to have concomitant procedures such as aortic root repair because the valve is stuck. They have to, there's root injury, or they have to replace the entire ascending aorta. Sometimes they have to have concomitant CABG or mitral valve repair. So multiple procedures. And, of course, these patients are elderly and sick and have comorbidities. So in looking at this registry and some other registries, the mortality at 30 days, when you look at TAVR explant, is not trivial. It ranges from 13% to as high as 20%. On the other hand, redo TAVI is a very, low-risk procedure as long as the anatomy is good. Raj Makar just published the data from the STSTBT last year, and the outcomes were excellent. Of course, we don't know the denominator from that study because, presumably a lot of patients were excluded because of, inadequate anatomy. But at least based on what we know, based on what we have, the mortality at 30 days seems to be lower with redo TAVI compared to TAVR explant. So this field obviously is evolving, and we are learning more and more as we see more patients with TAVR failure, and and we treat them based on their anatomy. So anyway, from my portion, the main message was that the Navitor platform is a best of both worlds strategy and a good option for a redo TAVR in the future by virtue of the intraannular leaflets. And based on some of the simulations, it makes sense that the risk of coronary obstruction is going to be lower with a second-time TAVR with this platform. Thank you. I will pass on to Dr. Sultan for the next part of the presentation. If there are any questions, I mean, we can discuss this now or take the questions later.
Yeah, why don't we take a few minutes, Bassam, if you want to just do a Q. I think there's a lot of, a lot of things that you just went over.
So, no, Dr. Goel, I mean, that's a beautiful overview about, the risk plane, the different kind of modality for TAV and SAV. But what strikes me the most is, the high risk for TAVI explant. I mean, it's really almost 15%.
Yeah.
compared to a redo TAVI, which is really less than 4%. So really what it goes exactly what you're saying is having something that is the best of both worlds. You have a valve that gives you the best EOA you can see, a single-digit gradient. It is self-expanding with an annular design, with a large cell access. So theoretically, that should be a valve that should have the least impact and the least need for explant. I mean, we need to pick a valve that will require the least explant need compared to the other platform, because that open up the door for the lifetime management. And like you said before on the slide, where you can do TAV and TAV and TAV, and maybe that would be the future, but the data is limited. And but as data goes on and gets more favorable, that may be a potential option. Our program is not a huge fan of the second option you have, where we do a TAV and then explant and SAV. We are mainly either the first option or the third option on this option. How is your program, Dr. Sultan, from a surgical standpoint? Which option do you prefer?
Yeah, I mean, I think more than, I mean, you know, we look at it a little bit comprehensively. I mean, I think we typically go for the first option unless, you know, I think if you're over 80, it doesn't matter how good of an 80-year-old you are. I think we go down the number 3 option. I think, you know, in young people, and, you know, and I think that what young is different in, you know, in Houston versus Kansas versus LA versus New York City. You know, you go to the coast, I think there's a lot of 60, 50-year-olds that are getting the quote unquote, at least being sold the third option, no questions asked, right, with a plan. And that's the reality. What I would say is the following. I think in a low risk patient who obviously a lot of them are bicuspid, the outcomes from a surgical AVR are exceedingly good. With nearly, it is with, I mean, it would be exceptionally rare to have an isolated AVR mortality or stroke in a low risk, but, you know, particularly a bicuspid patient, right? So I think we typically go down the first route. What I would say is that, you know, a couple of points that you made, you know, which is number one, having an intraannular valve like this with supraannular hemodynamics, it is outstanding. It is really a gift down the line. I think that's where you can actually maybe, and you know, I think this is the beauty of the Envision trial, and hopefully when we're on the other side, we can say, okay, we finally have a valve that doesn't give you a double-digit gradient routinely, and is an intraannular valve. The reality is 80% of this country, 80% of the operators, predominantly interventionalists, are putting in an intraannular valve that is going to give them a double-digit gradient down the line. So those valves we know are going to fail. I think SMART trial was very scary. Nobody expected a mortality difference in those small annuli patients. And I think what Sachin's talking about, I mean, it's reality. We've got to be able to talk about this. And I think if we're planning for TAV, we've got to start with a good valve the first time around to set up a foundation. Your foundation's bad, everything else down the line is not going to be any good either.
Yeah, I completely agree. In our program, we do the same. I mean, you know, we actually follow the guidelines very strictly. Less than 65 years of age, not surgical risk, not high surgical risk, surgery is the way to go. More than 80, TAVR is the way to go as long as their anatomy is good. 65 to 70 is always an individualized decision making. And, you know, surgeons know this better than any of us. The surgeons always say the first cut is the deepest, you know, meaning, you know, you have to do it right the first time, be it surgery, be it TAVR. You have to pick the right strategy the first time around. That has important bearing on what happens down the line.
Absolutely. And I think putting a 20 or a 23 sapien in a 60-year-old or a 65-year-old is not good either. Yeah, there's a TAV and TAV option, but what are you going to do the next time around? I mean, you're leaving them with significant patient-prosthesis mismatch the first time around. So,
and the solution, I don't think the solution is TAV or explant. I mean, if someone will tell you that, I mean, definitely it can be done. A good surgeon can do it. And it should be, in my opinion, a last resort. So I don't think it should be like in the original plan. Oh yeah, we're gonna do an explant when they're 80. That's really high risk.
Yeah, and I'll make a comment on that. I think it has less to do with, you know, the TAVR explant mortality has gone down considerably. I mean, we have a very low single-digit TAVR explant mortality. The reason I think is all the other things that come with it. Today, if you see a 70-year, you know, let's say an 80-year-old man who's kind of intermediate or high risk, and we are doing a TAVI in them, there's a very good chance we're not going to go after a 50% mid-LAD lesion. There's a very good chance we're not going to go after a 70% PDA lesion. There's this extremely good chance those patients are not getting ablated before or after the TAVI for their AFib. You know, they may be getting a Watchman if the interventionalist does Watchman at the same time. So yeah, but the reality, you're not treating any of those things. 3-4 years later, guess what? That 50-60% is now real. Now that patient needs a cabbage. That mild or moderate MS, which we said we'd ignore, now is real. And so what I find in our experience, the majority of our TAVI explants, it's not a technical issue anymore. We are beyond that. I mean, most of us. What I would say is it's all the other stuff. So it's very common to see, okay, now you got to do a double valve cabbage, right? So comparing a redo TAVI versus a TAVI explant, no longer, you know, apples and apples. So.
Exactly. And, you know, I just want to say one thing. There's a question in the QA about bicuspid. Just for now, the Navitor is not approved in the bicuspid system. The Envision trial is looking at the bicuspid as a registry and as an arm there, but for now, bicuspid is not. But in general, in our program, if we have a young bicuspid patient, you really have to twist my arm not to do surgery. This is a surgical patient until proven otherwise. When they're younger, small annuli bicuspid, bicuspid is different than tricuspid. It's to be treated more aggressively. If we can do surgery, that'd be better. It's different.
Looks like there is another question there. In TAVR and TAVR, when would you recommend a snorkel procedure? So, you know, that's a challenging scenario. You know, this is somebody who has a degenerated TAVR and their coronary obstruction risk is high. I'm assuming that's what the question is relating to. So if the coronary obstruction risk is high, then, you know, you really have to think about what your options are, how you want to manage this. Is this patient, you know, a candidate for TAVR explant and surgery? You know, assuming that they don't have a whole lot of other things, as Dr. Sultan mentioned, TAVR explant and having, you know, surgery may be an option. But if you really want to do a TAV and TAV, you have a couple of options. In centers with expertise in doing a basilica, basilica may be an option. Now we are learning more about something called the unicorn procedure, which is, you know, a similar concept of, you know, perforating the leaflet, but, you know, technically maybe less demanding than a basilica. Of course, there's not a lot of data. There are case reports and anecdotes, and, you know, we've seen cases in conferences. That is an option. But if you don't want to do leaflet modification, then of course, a snorkel stent procedure may be an option where, you know, your coronary obstruction risk is high, but, you know, you don't have the expertise or the feasibility to do a basilica, or anatomy is not good for a basilica or unicorn, then you can certainly do a coronary snorkel stent in those cases, and then do a TAV and TAV. That is an option. Of course, we don't have a lot of data on this. There are some reports. You know, I think the largest snorkel stent series is from Italy, published in JACC Intervention, and you know, that can be done. And we've certainly done these cases with a snorkel stent when leaflet modification is not feasible.
So I have a question to Dr. Sultan from a surgical standpoint, and it's also in the Q&A here as a small question. And so, what if you're in a center not like other centers, like, you know, you have surgeons who do not do root enlargement, and we're talking about these young population, like a 67-year-old patient, tricuspid, not bicuspid, tricuspid, severe AS, but it's a small valve. So what would you recommend to these? Because I see a lot of people ask me the same question. Would you say, hey, okay, operate and put a small valve? Would you say operate, put a mechanical valve? Or would you say just, you know, get a TAVR, get something that is annular with good hemodynamics, self-expanding, and move on?
Yeah. So I think it's a great question. And I think it's like saying, you know what, you're sending a patient for 3VD and they come back with a Lima LAD, right? So it's sternotomy Lima LAD. You're probably not going to send them a second patient again. This is no different, honestly. Okay. So I would say, number one, I think if you don't feel comfortable doing it, send them out. The reality is that I think, again, we're past, this is the third or fourth reincarnation of root enlargements. I think surgeons have gotten significantly better, both with outcomes and with techniques, and primarily because they have to be. As I said, having an isolated AVR mortality or putting small valves is a big no-no in today's world. It just doesn't happen. You can't do that, right? So I have to be able to look a patient in the eye and saying, okay, what is the advantage of surgery? Why are you going to have a scar on your chest, and what are we going to do that's going to be different? And I have to be able to say, okay, fine, guess what? When we do it, you're going to get this size valve. And next time around, we're basically guaranteeing them a TAVR if we put a tissue valve in. And this is what I tell the surgeons all the time when I talk to them. I said, listen, anytime you put a tissue valve in a young man or woman, you're guaranteeing them that they have to have a TAVR down the line, okay? Which means that it is your responsibility now to put a big enough valve in. The other side of this that we don't talk about much, and I think has zero discussion in the interventional community that I would encourage you all to think about, is mechanical valves. Mechanical valves have a survival benefit up to 60, 65 years of age. There are very strong data to suggest that. And the EOA of a mechanical valve, the EOA of a 21 millimeter St. Jude valve is the same as a 25 millimeter or 27 millimeter in Spears or Medtronic, Evalis or an Epic, etc. So even a small mechanical valve has phenomenal hemodynamics. And so that's just something to remember and think about as you refer patients. And I remember one of the senior cardiologists used to tell me when I was a young surgeon, he would say, listen, and this was way before TAVI, he would say, if you can get bigger than a 25 tissue valve in, put a mechanical valve in that patient. He would tell me that. Now I get why.
That's beautiful. So do you think we should move to the case, Dr. Sultan?
Yeah, sure thing. Absolutely. So this is a fairly, here we go. Okay. So this is a fairly straightforward, what I would say, high-risk patient, a 79-year-old woman on end-stage dialysis, has a fistula, stable multiple myeloma, has PAF, on anticoagulation, STS of 12%. And again, part of that is from dialysis, part of that is from AFib that elevates her STS prom. It's hard to get an STS prom of 12 nowadays for an isolated AVR. Deemed high risk by the valve team. Echo demonstrates, again, classic severe tri-leaflet AS. DVI was a little elevated, unexpected, but by gradient, by peak velocity, etc., we felt very comfortable about that. This is what her anatomy looked like. Again, the right sinus is a little bit smaller than the other sinuses, so just something to keep in mind as we look at sizing. But when we look at it, we also want to see how are we going to do a pre-BAV on this patient. So we do a pre-BAV on 100% of patients with self-expanding valves, and we typically use not necessarily the mean, but the smaller diameter here.
So Dr. Sultan, can I ask a question about the previous
please.
one? I mean, so I see like a calcium protruding in the annulus. Mm-hmm. So what's your consideration when you see something like that? I mean, is this something that pushes you into a self-expanding or balloon expanding?
So, I think it's interesting. I think self-expanding valves tend to be a lot more forgiving. You're almost doing it in stages, right? I mean, you're going to pre-BAV, give them a little break, then set a good foundation. And I tell the interventionalists, listen, what do you do? This is the first thing you do before PCI. You prep your lesion, and that's basically what you're doing here, right? So set it up, put your self-expanding valve in, and if you still need to do a post-BAV, which is relatively uncommon, we'll do it. I would say that this is not as extensive as one would expect in a dialysis patient, right? I mean, I'm sure you guys have both seen, I'm sure, ton of dialysis patients with heavy MAC, aortomitral continuity, et cetera, et cetera. And I think I would prefer a self-expanding valve in this situation.
And I agree with you, especially with the navitor, because the wider cells, I found that they conform better to the calcium that's protruding. And then you have the special, the paravalvular skirt, the skirt on the outside. It's like a parachute. It really, I found it to seal much better. So I try to use more navitor when I have this protruding calcium to minimize PVL than anything else personally.
I think that makes sense. The access here looked very reasonable, transfemoral, reasonable bifurcations. So again, looking at the CTA, coronary heights were fine, sinuses of Valsalva. Again, right sinus was a little bit smaller, but again, access was fine, no steep angulation. We felt that a 25 millimeter valve would be good. And again, anytime we're on the border, we tend to look at the sinuses. And I think the sinuses tell us where we should go. Because again, you want to avoid sequestration. You're thinking of, not necessarily in this patient, but TAV and TAV. Now, something to think about in this patient, and we can talk about it, in our discussion, is in a patient on dialysis who is going to have pretty rapid SVD, does it matter what kind of valve do we use? Bovine versus porcine leaflet. Do hemodynamics matter in this patient? I would say they really matter in this patient, right? This patient is probably going to, despite her age, probably going to need a TAV and TAV down the line, and probably going to, need coronary access down the line for sure, right? So this was our case plan, 25 millimeter Navitor valve. access through the right side, diagnostic through the left side. We still use a temporary pacemaker in every patient. Circular or a Safari guide wire, I think either work. We tend to gravitate towards circular. It essentially works just as well as a Safari. We pre-BAV with, we used to use Z-meds routinely, and we've used, again, to completely to a non-compliant balloon. EKG, pretty straightforward. So again, high-risk patient, good anatomy. We talked a little bit about sinus segment diameter, small annulus, and then, again, what would be better, bovine versus porcine? But what we do have to know is that this patient's likely going to need something down the line. Anything different either of you guys would think about or do here?
No, I think I completely agree. I mean, dialysis patients, no matter how you do their valve replacement, surgical or transcatheter, they have a higher risk of early degeneration and requiring another intervention.
Absolutely. So I think Boston was pointing out, again, we use a cusp overlap technique. The non is isolated here. You see a little bit of calcification at the level of the annulus that Boston was talking about earlier. We've crossed the valve, get our circular wire in. We try to be a little bit high, as you can see with the balloon. Operator 2 is almost pulling back the balloon as we do this. As we do a BAV, again, we notice that staying a little bit on the high side, more aortic, helps us from a pacemaker concept. Now,
so how important is pre-BAV for a navigator? I mean, we don't do BAVs anymore, pre-BAV for the other valves.
Yeah, so I think a lot of it is in comfort, and I think it's one of those things. I know a lot of places that, like you said we never do a pre-BAV for any self-expanding, and I'll tell you, we always do a pre-BAV for a self-expanding. And I think the happy spot is somewhere in the middle, right? So I think there's some patients, you've got a lot of cusp calcium, you want to pre-BAV them. I think the opening force, a lot of comments about opening force or radial force for Navitor versus Evolut. I think the opening force for Evolut is a little bit greater than Navitor, but the eventual radial force are the same. So I think it's just something you have to keep in mind. This is us again in cusp overlap deploying, and Navitor with vision really having those commissural markers is huge for us, right? So I think the amount of aortograms we take, the amount of pictures we take, we can really tell comfortably, and you can see even on a PowerPoint screen how clearly visible these are. So we take a look at it. Again, we'd like to stay at 3. We're not huge fans of trying to make this supraannular and land them at 0. Again, we want to think about coronary access. We want to think about TAV and TAV. And then we swing over to LAO and take a picture again, just to make sure that the left is again going to match up, and which looks good. This is fairly common. I think most self-expanding operators will do this, where they'll pull the wire back to neutralize the nose cone a little bit and take the tension off. And then we go very slow, and we try to rapid pace through this. And then once the tabs are released, generally you'll see 2 tabs releasing and 1 tab kind of hidden. Kind of have to swing over and make sure with the gantry to make sure you've released everything. And we use both. Again, we use both the invasive and non-invasive gradients just to make sure that we are comfortable and happy with everything. Okay. Now, the big thing, and I tell people this all the time, and I think both of you are expert operators from nationally renowned centers. It is not that. I mean, this is our fellows doing the cases, with us. This is with our supervision. I mean, these are not that challenging. I think the common thing we hear from, again, majority of folks that are balloon expanding exclusive operators are, well, I'm done by 5 by noon or something along those lines in one room. And I think it's important not just to think about that, but to think about all the number of years this patient's going to live with this, whether you talk about SVD, whether you talk about small annulus, hemodynamics, TAV and TAV, et cetera, et cetera. So I think there's ways to be very efficient with this and expeditious with this, so you're not spending hours and hours analyzing. So I think as long as you're methodical, this is very teachable. I think you can democratize this technique, like both of you have spoken to, many teams around the country. So I'll stop there and I'll hand it back to you, Boston.
Asim, you're muted, I think.
Yeah, thank you. No, that was a beautiful case, Yves. I mean, well done, well deployed. You just nailed it at the 3 millimeter mark. What I could see from that is I love how the valve self-centered itself, and you were on equal side on both sides, on the non-coronary cusp and the left coronary cusp, and there was not like a big difference in deployment. Uh, it seems it was pretty routine with you, and that's the beauty of that. I love the large cell design. I mean, it's quite obvious how you can see it there. It's quite obvious how you can reaccess the coronaries. So that was beautifully executed, and that was not an easy case. I mean, there was no PVL at the end, despite that calcium jetting out, and I didn't see any pacemaker, nothing like this. It was
Yep.
pretty good deployment. So we're gonna just talk a little bit about this, and I'm gonna ask Dr. Goel a question. So Sachin, I mean, it seems there's a lot of benefit of the Navitor, and it seems that what's really limiting us right now is the actual commercial indication. I mean, it's just for high risk right now. Definitely, the Envision is going to hopefully open up a lot of the doors for us. So, what is your pathway in your program right now? When do you pick Navitor? When do you pick the other valve? What's your thought process going through this? Is it just for small annuli? What if you have a bigger annuli? So you would not use Navitor in these cases if they're high risk?
No, I would use Navitor I mean, I don't just use it for small annulus. I mean, I know the focus today was small annulus, but we use it for small and large annuli alike if the patient is high surgical risk. Um, you know, uh, Personally, as we discussed, I really like this platform, and we're using this more and more. We had great experience in the trial. Now we're using it commercially. We're using in the Envision, as you know. So we've had very good experience with the valve, as pointed out. All the key features. The valve is also very stable. The delivery system is very stable. The valve doesn't tend to move. When I talk to a lot of the operators who are mainly balloon expandable operators, including some of the people in my hospital, some of the concerns they've had with the self-expandable platform is that, oh, the valve moves, it dives, it does this or that. But the big advantage with the Navitor that we have seen, at least I'm sure you have similar experience, is this valve deployment is very, very stable. The valve does not move at all. It is a very predictable deployment, as Dr. Sultan showed elegantly. You follow the steps, the cusp overlap, take a shot, swing over to the LAO and take a shot. The valve is very stable. It doesn't tend to dive at all. So yeah, I mean, in our experience, for high surgical risk, small annuli, large annuli, really doesn't matter. We tend to use it a lot for all the approved indications, which is high surgical risk patients.
Definitely. And just to ask some of the QA question right now. So Ibs, when you do a pre-AV with a Navitor, how often are you doing post-BAV? I mean, we don't see that a lot in our program. It's very rare when we do a good pre-AV. Are you seeing that differently in your program?
No, I think, I'd say probably 10% of the time. And I think they're probably high risk anatomy. We try to push the envelope a little bit with what we think. I mean, for example, I think bicuspid is a good example, right? And I think even if you rupture the raphe and tear the raphe, you're putting an Navitor. And, again, I know we're not supposed to talk about bicuspid, but, I think if you have a high risk anatomy, I think it were more common, but I'd say about 10% of the time, 10 to 15% of the time. It's not that common.
Yeah. Same thing, Sachin?
Yeah, same thing. I mean, I would rather pre than post. And we're finding good outcomes, good results with pre. I think the analogy of the coronary stent is a really important one. We don't really just slam in a stent in a coronary lesion. We always pre-dilate, do the lesion prep. So we tend to look at it as more a lesion prep, and that serves it serves us well, and we don't have to post dilate frequently at all. I agree, maybe 10 to 20% or less for post dilation.
Yeah. And one of the question is how much do we rely on STS score by itself to assess high risk? And maybe that's a question for you, Dr. Sultan.
I think the STS, so first of all, I think the STS prom is not a great, it's not, in my opinion, great for TAVI. I think, patients need a more holistic view. I think there's a lot of 60-year-olds that have an STS of 10% and a lot of 80-year-olds that have an STS of 1.5%. I think as long as you've got a serious, and I mean, not just a, rubber stamp, I think if you got a serious heart team of a talented interventionalist and surgeon that can sit together and say, okay, fine, this particular patient's high risk because of so and so, which may have to do with frailty, which may have to do with something else and not just STS prom. Every year, what the STS proms were in the trials for partner 1, 2, 3, even core valve, they're very different now. Every year that prom goes down because every year the O2E changes for surgical AVRs around the country. And so it becomes harder and harder. So I always ask, I mean, our nurse practitioners, okay, how did you get an STS so high? It's so hard. And so it's inevitably bad lungs, bad kidneys, anemia, or you know, or some sort of little things here and there that do it. Or a good example is COPD, unknown. So there's certain characteristics that really throw the calculator off. But I think truly to do good service to the patients, you have to have a holistic review and say, listen, this person may be in their 80s. They may be extremely frail in a wheelchair. They could be in their 60s, could be in a wheelchair, frail, dialysis. Their STS may not be that high, but that's likely a high-risk patient that is not going to have that life expectancy. So I think focusing a lot more on life expectancy is the way to go, as opposed to just having a reflex STS, conversation.
And Sachin, I have a question. So it's one of the QA here. So how do you respond to people who constantly claim that they do 20 millimeter balloon expandable valve all the time in the small annulus? I mean, and they have no problem with that and there's no issues. I mean, what are your thought process for this? I mean, if your fellow asks you that, what do you tell him?
Yeah. So first of all, I've never used a 20 millimeter sapien valve. Never, ever. I think it's not a good idea to use a very small balloon expandable valve, like a 20 millimeter valve. We've seen these from other centers. These patients, these have obviously, some of these have been our redo TAVR, not implanted in my center, but implanted elsewhere, including some reputable centers. Unfortunately, these valves don't last long, and we've seen early failures, and we've had to do TAVR explant when their surgical risk was acceptable, followed by an annular enlargement by Michael Reardon or one of our other surgeons. In patients who are high risk, we've done redo TAVR with a tall frame and short frame, which is currently off label, but I would obviously never put a balloon expandable inside a balloon expandable. So that's sort of been our experiences. Firstly, we at least in I've never used a 20 millimeter sapien. I've never felt the need to use a 20 millimeter sapien valve. I think that's just not a good practice. These valves will fail. We've seen them fail. I think for a good TAVR operator, it's very important for a good TAVR operator to be facile with both platforms, a balloon expandable platform and a self-expandable platform. You can pick and choose which self-expandable platform you want to use. Obviously, based on what we are seeing here and hearing, and with the Navitor, the audience has heard, all of us talk about it, the advantages of the Navitor. So I think more and more we are seeing that the Navitor platform is becoming our self-expandable platform of choice in appropriately indicated patients. So that is, and the hemodynamics, all the things that we already talked about is what in the last 5 years, just to give you my example, in my center, we've gone from 1 TAVR center to 5 TAVR centers. We have 8 hospitals in this area, and other centers have started their TAVR programs. And some of the operators who started those programs have trained exclusively on balloon expandable valves in their fellowships. So what we've done is we've invited them to come and do their cases here, especially firstly the small annuli patients. For example, if they were going to do a 20 millimeter sapien, say, hey, why don't you come here? You can implant either an Evolut or Navitor now, and so that we can supervise you, we can help you, and that'll give you more confidence. And they've liked doing that, and now some of our other satellite programs are starting to use more and more Navitor platform, particularly in the small annuli. So that's been a huge benefit when the implanting physicians can actually learn from expert operators like yourself and centers that have good experience.
That's a great idea.
Yeah, I would add to Sachin's point, which is you can't claim to be such a good operator and only be enslaved into a particular platform. If you're really that good, you should be able to get a good outcome. And I tell some of my partners who say, whoever size, I mean, I can't remember if we've ever put a 20 sapien in, but if anyone does size, I said, and I tell them, I said, would you be okay with a 17 millimeter or 19 millimeter tissue valve? That's what you're doing for this patient. And somebody, I think one of the comments said, oh, they routinely have no issues. I'm sure they have no issues in the lab. Of course they have no issues. They probably have no issues at 1 month, but that patient's coming back in a year or 2 years. They're not going anywhere.
All they're doing is they're kicking the can. So, I mean, I agree. I mean, so the main
making
question
it
would be for me
difficult
is how long have you been doing TAVR, and have you been doing it for over a decade? And that's when you can see exactly when they're going to start coming back or not. But that's a problem when you do 20 millimeter valve on this one. I prefer to get a mechanical valve that is smaller than get a tissue valve like this, quite frankly.
And it's a lot of this. This is like PCI in the 90s, right? I mean, like everyone is doing it. Everyone wants to do it. And I think, some of you who've done thousands of these, and now, you have a much more holistic view. Okay, this is what works. This is what doesn't work. I've already made these mistakes. Don't make these mistakes, yourself. So I think that's I'm glad that, everyone's doing this. This is fantastic. So.
No, any thoughts to end? I mean, we have like a few minutes left. Dr. Gowal, any thoughts about before we end this? Any final thoughts?
Well, I think this was a great summary. I really enjoyed this session and discussion, hearing from you and from Dr. Sultan. It's always great to, hear, the surgeon. Our team is critical to this. We really enjoy working with our surgeons, Mike Reardon and others. And so, again, specific to this platform, I see this as a huge step forward in the TAVR technology. We've come a long way, right? We all remember doing TAVRs, with 24, 26 French sheets, transapical access, and, how things have changed. And in a span of 10, 12 years, we've seen, numerous iterations of all kinds of valve platforms. And this really, I think, is, one of the, best, advances that I've seen in the technology, really offering the best of both worlds, where you have uncompromised coronary access, you have low gradients, self-expandable hemodynamic benefit, yet a intra-annular valve, and really a future-ready valve to be able to do a redo TAVR in potentially many, many more patients, as we saw in those simulation studies. So to me, this is a big winner, and I think we are all eagerly awaiting and enrolling, as you know, in the Envision trial to move this forward to the other patient populations where it is not approved yet.
Dr. Sultan, any final thoughts?
No, I think I'll take that from Sachin, and I'll say that, I think, Bassem, your leadership on Envision, I think everything that operators and Sachin and all other, lead operators around the country are doing to help with Envision, because this is a very good valve for a high-risk patient, okay? But I think this will be a great valve for a low-risk patient. I think this is the valve that you want in a young low-risk patient. I think when you're talking to the 65, 70-year-old, for potential TAVI, and they really only want TAVI, I think right now I feel very uncomfortable saying, okay, I can get you really good hemodynamics, but we have to hope that this valve's going to last you for, 20 years, because you may not have a TAV and TAV option, or I can give you okay hemos. This valve's definitely going to fail, but at least you have a TAV and TAV option maybe down the line. So I don't really feel good about having that conversation. But I think, once Envision gets through, I think that's when we can really have a serious conversations with young patients and say, okay, fine, at least now we have a solution that theoretically makes sense.
No, that was amazing. Thank you both. And that was a fantastic event and presentation. I want to say thank you to Dr. Sultan and Dr. Gowal for their time, their leadership, and all the effort they're doing in the structural world and in the navigator world. And I want to say thank you for Abbott for this opportunity to present to everyone, to really kind of settle really or level the playing field about the benefit of the navigator. Like Sachin said, it's the best of both worlds. So looking forward for the future to finish up the Envision trial, and hopefully everyone who is doing it can enroll with us. And we'll see you both guys in New York Valve next week, hopefully.
See you. Thank you.
Thank you, everyone.
Thanks,
Thank
Bas.
you. Bye.
Thanks.